अभी प्लस को दबा दो।
We are live now, Doctor.
Okay,
I
thank
can
you.
stop and ask questions.
Good evening, respected seniors, colleagues, and all the wonderful and dynamic residents who have logged in today. It gives me immense pleasure to welcome you all for the 7th masterclass of the online postgraduate teaching program, which we have named Kaksha. Kaksha is a ROS initiative, which will cover all major topics over a period of next 2 years with the current curriculum of postgraduate ophthalmology residency program in India. We'll be bringing in the best of national and state faculty experts to show their knowledge and interact with you. The residents who have logged in are also encouraged to put any of their doubts in a fearless manner in the chat box, and every question will be answered comprehensively. Coming to this class, we have today with us my teacher, Professor Rohit Saxena, sir, from RP Center, AIMS, New Delhi, one of the leading strabismologists of not just India, but internationally, and to enlighten us about one of the most important and relevant topics, at least for me, strabismus, basics and its workup, which should be known by every ophthalmologist, whether he or she is practicing strabismology or not. I welcome the ROS President Khilani sir, President-elect sir, Dr. Sanjeev Desai, and our dynamic secretary, Dr. Ghulam Ali, for today's class. Today's hot seat presidents are Ayushi Verma, Ayushi Gupta, Kavita. They are all final year postgraduates from different colleges in Rajasthan, and the teachers are and the HODs are encouraged to interact with them freely with the chat box or with the audio on. And there will be a grand quiz with exciting prizes at the end of the presentation. So keep a strong vigil and listen carefully to win prizes. Now I invite Dr. Ankur Sinha, a leading squint specialist from Jaipur and the director of Max Vision Eye Hospital, to moderate today's session and give a brief introduction of Dr. Rohit Saxena, sir. Dr. Ankur Sinha, over to you.
Yeah, thank you, Vishal, and welcome everyone on behalf of Kaksha and ROS. Welcome, Professor Rohit sir. Rohit sir has been a friend, teacher, mentor, and guide for me, and he is presently a professor at RP Center and heading the strabismology unit of the RP Center. He has more than 250 index publications, and he has been conferred more than 32 national and international awards. He has edited 3 books and authored more than 32 chapters. He has been an invited speaker for more than 300 national conferences. He is a member for project review of committee for Department of Science and Technology. He is also a subject expert committee member for DCGI, and he has also held various important posts like Secretary of DOS, Editor DOS Times, Editor DJO, and in AIOS also. He is a reviewer of 12 international index journals. He has done more than 42, his candidates have done more than 42 theses. He is a PI for 8 and a co-PI for 5 projects which are funded by the central government. Welcome you, sir, and welcome everyone for the class. Professor Rohit, sir.
Thank you, Ankur. Thank you, Vishal, for the opportunity, and of course, pleasure to meet so many other wonderful personalities from ROS, Dr. Virender, Dr. Ghulam Ali. And again, thank you for the opportunity, ROS. I think it's a wonderful platform giving us access to the residents and residents the opportunity to interact with us. I'll start by sharing my screen, and I hope it is visible.
Yes, sir.
Yes, sir. Yes, sir.
Great, thank you. So I'll just briefly run through workup strabismus. As is my habit, maybe Vishal and Ankur will remember, every time I make a presentation, I stop and ask questions whether I'm supposed to or not. And in this case, of course, I've been asked to, so that's a pleasure. Because my aim is that, keep the people awake, because usually when strabismus or neuro-ophthalmology gets discussed, everybody is kind of thinking of other better things or looking at their watch as when this is going to end. So I enjoy, the discomfort of people when I stop and ask questions. So, and now, of course, in this, of course, Vishal has so kindly, asked me to do so actively. So I'll just stop and ask questions. And of course, anybody can halt and ask. I mean, I really don't mind, being halted. So this is a gross overview of actually everything that we will talk, or, you actually are going to read up subsequently. This is a kind of concise. So squint or strabismus can be apparent, which means it appears there is a squint, but there isn't really. It's a latent squint, which means that at some times the deviation manifests itself or presents itself, but at other times it is not visible. And finally, of course, a manifest strabismus or a heterotropia. So tropia is a manifest strabismus, phoria is a latent strabismus. Manifest strabismus would be there all the time. Whether it is there in all gazes or not will be dependent on whether it's a competent or incompetent strabismus. So a competent strabismus comes from the age-old world of the Cold War commies. So commies were marching together. So same is about competent strabismus. The two eyes move together, although there is a deviation in one of the eyes. So the amount of deviation remains constant. So it's like a zero error that remains the same wherever the eye moves. And an incompetent strabismus, where the deviation is different in different gazes, it may actually be there at some times and may not be there in other gazes. So it's incompetent and competent, and the incompetent can be because of a paralytic muscle, a restrictive cause, which is preventing the eye from moving, and extremely rare spastic. So this is the entire sum substance of strabismus pathologies as we talk about. I talked about pseudostrabismus. Latent is strabismus that there is a tendency to squint, but active mechanisms like accommodation, like fusion, helps to control this strabismus. So that patient may present with deviation sometimes, like an intermittent divergent squint. The patient may present when he's not concentrating, looking far into the distance, daydreaming, just woken up from sleep, conditions in which the fusional vergence mechanism is a bit weak. So sometimes even when patient is ill, has fever, the patient will manifest the strabismus. So when the brain cannot spend energy, so fusion is an energy spending process. The brain actually utilizes ATP to fuse those slightly dissimilar images into one. And when the brain is not able to do this active procedure, the patient may actually start squinting. So this is a latent squint. And of course, as I said, manifest would be there all the time. So let's now go on to how we are going to work up a patient who walks into our OPD. Key questions to ask. Of course, this is not a comprehensive list, but again, always remember in strabismus, particularly when you're working up with children, a good history is very, very important because it really tells us a lot of things that we may miss in examination because the child may not be cooperative at all times or may not be comfortable with you. So a lot of experience of the parents or the caregiver help us to understand what's going on in the binocular system or the ocular motility of the child. So of course, the key questions are presenting complaints. They can come with asthenopia, diplopia, or just malalignment or strabismus or squint. It's important to ask for age of onset because earlier onset, longer durations have poor prognosis as far as binocularity is concerned. And if there is an associated constant angle squint or a constant eye that is squinting. So if constantly the left eye is squinting, there is a high chance that that eye may suffer amblyopia or become a lazy eye and therefore have subnormal vision. So these are important questions because they give us an idea. Sometimes in a small child, we are unable to get the vision because the child is too small to cooperate on, say, a Snellen's. So the fact that the child has a history of a constant eye that is squinting is something that may tell us that this eye may actually be having amblyopia. Whenever you have doubt, and we'll see sometimes in patients with, say, superior oblique palsy, you ask for childhood photographs. There has been times when a young adult walks into the OPD and says, has that he has seen his left eye is not abducting for the past few months. And you examine the patient and you realize that he has a Duane syndrome, which is a congenital anomaly. But he's noticed it now. So you ask them for old photographs and see for head postures. And those are some hints or examination of photographs that can tell you that this was a congenital anomaly and he doesn't need to be examined or investigated extensively for a recent onset paralytic strabismus. So sometimes when in doubt, you need to look at childhood photographs. Then is the pattern or deviation, essentially meaning it's intermittent, constant, same eye or alternating. Is there any precipitating factor like trauma or fever? Again, it's not essential that the trauma and fever may be resulting in a peritic strabismus or paralysis, as I discussed, sometimes a break in fusion may precipitate a competent strabismus also. Something that we are frequently seeing, which we have unfortunately seen over the past 3 or 4 years since COVID has struck, where we found young children, young adults, watching a lot of near related work and therefore precipitate with acute competent esotropia. So, of course, you need to ask for precipitating factors. There is developmental history is very, very important, because a lot of these children who have developmental issues may have associated strabismus, besides having other associated problems like refractive errors or other corneal or retinal pathology. So it's very, very important to have a developmental history, understand if they have any developmental issues. And finally, of course, history of what treatment they have undergone: refraction, glasses, occlusion, any previous surgery, whether it's for strabismus or for any other cause, because that may help us to understand.
I request others to please mute because it is interfering a lot. Admin, please mute others.
So,
sorry, sir. I mean, admin, please mute others.
So we know that examining children can be a challenge. So keep attractive objects, maintain eye contact with the child. First, you need to put the child at ease. You may just, before you start examining the child, you actually can talk for a bit with the parents, so the child starts realizing that this person is not an adversary and parents are comfortable with him. So he's a friend, and therefore they may warm up to you over time. So of course it's a challenge, but you need to be a little sensitive to the needs of the child as you start examining. The most important first step is, of course, assessing visual acuity. In our profession, ophthalmology, the eye is supposed to see. So we need to know whether it's doing its most important and primary function or not. In adults or older children who are alphabetically trained, you can go ahead with Snellen's or ETDRS. But for younger children, you need to have some special techniques. So these are photographs of instruments. So we have the two Ayushis, and I think Kavita. Anybody who wants to tell me what's the top photograph, the middle photograph, and of course, I hope you can recognize the last one.
So the top
acuity card.
So the top one, this is the top one.
Taylor acuity card.
And if you look carefully in the screen, you can see that it's written here.
Cardiff, sorry, sir, Cardiff acuity card test.
So these are Cardiffs. This is
CAT 4 dumb test, sir.
Sorry?
CAT 4, sir, optokinetic dumb.
This is the optokinetic drum.
Optokinetic dumb.
This is the middle one, stellar acuity, right? So these are visual acuity testing devices for children. This is the teller, which is a grating acuity, is useful for children between 6 to 8 months to about 1.5 years. The beauty of this is that if the child, so this is based on what is called the preferential, both these tests on what is called the preferential looking test. So the preferential looking test means essentially that the child will preferentially look at an object versus a blank background. And the beauty of these cards are, they are called vanishing optotypes. These optotypes will vanish because the average luminescence of this square is the same as a corresponding square here. So if I'm not able to resolve this grating, this will appear like a gray, just like this side. So there will be no object for the child to preferentially look at, and child's eye will start randomly wandering here and there. But if the child can see the grating, he will preferentially look at this grating, and I can kind of get an idea of his visual acuity. These are Cardiffs. Cardiffs are for a little older children who can recognize a house, a cat, a fish, a car. So these are for about 1.5 to 2.5 to 3-year-old children, where again, they work on the same preferential looking principle and are vanishing optotypes. So these are Teller and Cardiff. This is of course an Okian drum. So if the child can actually see these gratings, when you rotate them, the eye will generate the optokinetic nystagmus, and that you can tell. Although it's not a great method, but these are ways, especially when you don't have any other method, these are ways you can actually identify the basic visual acuity. These are fairly accurate methods of testing visual acuity. Of course, for a little older 3 to 4 or 5-year-old children, You have others like the K pictures, you have HOTV. So you have a lot of other things for older children. And of course, if they are alphabet trained, you can actually try an tumbling E or an alphabet, an ETDRS or a Snellen's chart. So assessment of vision is very, very important because again, like I said, finally, the eye is meant to see. And in the early period when the visual system is developing, it's very important that the vision develops. Otherwise, the child becomes or remains amblyopic for a lifetime of problems. So it's very, very important to diagnose amblyopia. We talked about presence of a strabismus, particularly a fixed angle strabismus. You know, the eye that is constantly squinting is amblyopic. You can, of course, actually do vision assessment, or you can have resistance to covering either eye. So which eye in this child is amblyopic? The left eye or the right eye?
Left eye.
Great.
So right eye.
Left eye?
Right. Amblyopic, sir, left eye.
Why? Just, I mean, because everybody should know, that's the reason.
Yeah, why is this? Again, this is a very simple to do test. That the left eye is amblyopic. You are right, the left eye is amblyopic.
Answer resistance to occlusion of right eye.
So why?
Because it has vision in the right eye, but not in the left.
Great, wonderful, absolutely. So he's absolutely unconcerned. He's not actually seeing through the left eye. So you cover the left eye, he's not particularly bothered. But the moment you cover the right eye, he becomes unhappy because for him, that is the only seeing eye. So he's not seeing through it. So any child will get uncomfortable. So this is a very simple, easy to identify way to check for amblyopia in the absence of a squint. In the presence of a squint, a fixed angle squint or a fixed eye squint becomes a fairly simple and a quick method to understand presence of strabismus. And actually, that is why when we are managing strabismus or squint in a child, we prefer to do amblyopia therapy before we do squint surgery, because the very fact that one eye is constantly squinting is a clear evidence that there is amblyopia in that eye. And you don't have to actually subject the child to multiple difficult and not so great tests or have these tests with you. You can just by this know that this eye is squinting. And once he becomes an alternate squinter, once alternate eye starts squinting, you know that amblyopia is cured and you can go ahead and operate the child. So diagnosing and managing amblyopia is very, very important. Patching is the gold standard. Even now, I would still prefer patching over any other form of amblyopia therapy, although some great alternatives are available. Remember, distance visual acuity, near visual acuity, distance vision, not the final endpoint, near vision, crowding, speed of reading, all these things comprehensively, which comprise vision per se, and not just visual acuity, are parts of managing amblyopia, sometimes which we miss. And always remember to taper treatment. I've just given you an occlusion schedule, which we prefer to use in our center. So we patch 1:1, 2:1, depending upon the age of the child. Although now we have strongly moved to part-time occlusion. So in that condition, you do not have to switch the eye, and you can constantly put occlusion for 4 or 6 hours, depending upon the severity of amblyopia on the dominant eye. Of course, remember, full-time occlusion is always more effective, but compliance issues have forced us to probably think in terms of part-time occlusion as a good alternative. Good studies are available, and you should read the PEDIC studies to understand a little more about amblyopia therapy and what is a good amblyopia therapy plan. Next is the importance of refractions. We talked about vision, we talked about identifying amblyopia, and of course, treating them with patching, but anything before that becomes refraction. So refraction cannot be overemphasized in a child with strabismus or even amblyopia. So what is this first child?
Yeah, just compare the two pictures. Can you compare the two
this
pictures?
Child and this, I mean, this photograph, and they're not pre and post surgery.
So left eye isotropic.
Great. So what has happened to the isotropia now in the right photo?
So refractive errors.
So what? So we have given the child glasses, and what has happened?
Accommodative isotropia.
Great. So this is the diagnosis of accommodative isotropia. Like I said, like I've written, importance of refraction cannot be overemphasized. Isotropia, especially coming in a child, you must rule out accommodative isotropias. You can do that by doing an age-appropriate cycloplegic refraction. That is an essential first step. Age-appropriate cycloplegic refraction means that up to 6 or 7 years, we prefer to use atropine ointment, not drops. Ointment. Drops are prone for more side effects, particularly systemic, because they can go down the nasolacrimal duct and get systemically absorbed. The ointment does not tend to have that much of that issue. And prescribed glasses based on the retinoscopy, you do not need to call the child for a PMT. So just reduce the distance correction and you can go ahead and prescribe the glasses. And an accommodative esotropia child, that is all you would need to do. This adult, what is happening to this adult? Again, these are just... I think
first spot the difference in the pictures, try that what has happened in the one picture as compared to other, and then what can happen.
So this and this, what is the difference? There are two differences kind of a thing.
Don't be afraid, tell anything.
Bolo, nothing. Nobody's marking you. If anything, I am the one who's under.
Right eye hypertropia.
Right exotropia.
So there is a right exotropia in the first photograph. What happened to the exotropia? We just talked in the beginning that, you know, I talked about latent strabismus being corrected by fusional vergence. So in divergent squints, a good quality, so the basis of fusion is the brain should get good quality. If the brain does not get good quality images, how will it fuse the two slightly disparate images? So first step, even for divergent strabismus, is to get a good quality vision. So the moment his vision was corrected, he was able to fuse. So he moved from an intermittent divergent squint or a tropia to a phoria. It's not that his tendency to diverge has gone away, but his brain has now controlled it by fusional vergence. And this is something that is happening in all of us. Many of us are exophoric. You do an rapid alternate cover test looking into the far distance, and within a few seconds or a minute, you'll start seeing the image jump. Your phoria has broken.
So somebody has written convergence weakness is the cause for this exotropia. So could you clarify that why we would not talk about convergence weakness here?
So of course, just on one photograph, we cannot talk about convergence weakness. Again, convergence is an active mechanism. Convergence or accommodative vergences, all these are active phenomena that provide or require accommodative vergence. So convergence or accommodation you are seeing in this child here, an exuberant accommodative vergence. That's what we are seeing and responsible for esotropia. Here in a divergent squint, it is a fusional vergence that is keeping the eyes aligned, which is true for us also. But if the accommodative vergence sometimes can correct a hyperope. So this most commonly are myopes and they have poor vision for distance. But suppose this was a hyperopic patient, suppose his refractive error was hyperopic, then without glasses, there is a possibility that if he was a low hyperopic, he would have fused. Essentially, his eyes would have been aligned and then he would have generated the fusional vergence. So again, it's important to understand the baseline refractive error and the baseline deviation, because these dynamic factors like fusion and accommodation and vergences related to that can make an impact on the amount of or deviation. So this was an IDS corrected by a fusional vergence. Again, always check for centered glasses. I hope the residents know how to check for centration of glasses clinically, and you need not have to go to
Sir, I'm just stopping. Ayushi and Manish, do you understand the vergences? I mean, I'm just asking, sir, because like we're talking about fusional vergences and accommodative vergences. Do you understand them, but does it need to be clarified? The guy on the hot seat. Yeah.
Yes.
Yes, so vergence is
clear.
I mean, you understand now that that's not to be clarified and understood. I mean, we presume that you have understood it.
Sure. Great. Anytime, just feel free to stop if you come across anything which I try to keep it absolutely basic. But if you don't understand and you want to have your subsequent question on that, just keep going. You just stop me and ask. So I talked about centration of glasses. Centration of glasses are very, very important in strabismus. Why are centration of glasses important?
The basics of glasses, like do we have convex glasses as two prisms base in, and concave as two prisms base out?
So high-powered glasses have a prismatic effect over the deviated eye. I mean, forget a patient of strabismus, any spectacle lens also has a prismatic effect. And in fact, that is what in class 8 physics, when you used to learn that as you go further and further away from the center of the lens, the power of the lens increases. And this is because of the prismatic effect of the periphery of the lens. So as you move away from the center, the C along the central axis of the lens, you are going to, the light passing through an eccentric part does not go through a single point focus. So they are a little more powerful. So that's what is happening. So in low up to 3 or 4 diopter spectacle lenses, it's not so important. Although centration should be done for everybody, whether I have strabismus or not. One of the causes for headaches could be a poorly centered in a person. When you wear a new pair of glasses and you have a little bit of headache constantly, one of the very simple reasons could be an poorly centered glass. And you go for a spectacles, and the optician must do a centration based on the frame that you have used. So essentially meaning that the center of the lens should basically coincide with the visual axis so that there are no prismatic effects on straight ahead gaze. So in higher powered lenses, 4 or 5 and above, these become important. So you may just overestimate or underestimate a strabismus because of decentered or poorly centered glasses. And therefore it is important to identify, diagnose, get them corrected before you do your measurements or do your planning surgery. Subsequently, the first thing you look for any child is the head posture. So the head posture can be a face turn, head tilt, chin elevation up or down. And a huge number of causes can be there of head postures. Most common, obviously, is incompetence, strabismus, A or V pattern, nystagmus, one-eyed also, and occasionally refractive errors, particularly those who have a high cylinder. So this is a classical case of a right superior oblique palsy, congenital, and you can make that out because of a midfacial hypoplasia on this side, and this side is a little better developed. Although the right eye is a superior oblique palsy, he kept a head tilt onto the opposite shoulder to align the eyes. And because of that, this side of the face had a poor development and therefore has a midfacial hypoplasia as compared to this side. So this is a characteristic head posture and a facial appearance of a child with congenital superior oblique palsy. Again, anytime any question asked. Otherwise, we move on to measurement of ocular deviation. So the first step, so once you've seen the head posture, you want to identify what is the amount of strabismus. So the first test is a corneal reflex test or a Hirschberg test. You shine the light at the mid of the nasal bridge here. It will fall on both the corneas. In one eye, it will be centered as the patient will be looking at the light, and it will be decentered on the other eye. And depending upon the direction of displacement and the amount of displacement, you can diagnose whether it's an iso, exo, and the magnitude of deviation. So approximately 1 millimeter decentration of corneal reflex is about a 7-degree deviation. Grossly, you can remember edge of the pupil is about 15-degree, limbus is 45, somewhere in between is about 30. So these are gross ways to measure. Of course, ideally, you should do a prism bar cover test. We'll come to that. Looks can obviously be deceptive. So we talked about pseudoisotropia. A lot of children with epicanthal folds, telecanthus come to us with the parents worried that the child has esotropia. So you look at the corneal reflexes, you can see that they are well centered. You can cover any one eye. There is no movement in the other eye. So you know that this is an pseudoisotropia or a pseudostrabismus. And you can, of course, there is nothing precluding that this child may eventually go on to develop squint. And there is some work that has shown that many of these children had a higher tendency to go into strabismus. And therefore, you need to follow up these children. So always rule out pseudostrabismus. It's a very simple, easy to do test. To measure or to detect true strabismus, you'll do a cover test. You will cover what is the apparently fixing eye and you will see that the deviating eye will move to take up fixation. So place cover on the fixing eye and see the movement in the deviating eye. The prerequisite for this test to be successful is obviously the deviating eye should have vision, should be able to fix on the target, and should not have any motility defect. So if there is a motility defect, obviously the eye cannot come in to take up fixation. If there is no vision in that eye, obviously that eye is not going to come to take up fixation. So cover test to pick up tropias, a manifest strabismus cover test. Cover uncover test or an uncover test is for latent strabismus or heterophorias. You need to see the movement of the eye under cover after disruption of fusion. So the eyes come aligned, you can cover any one of the eyes. And when you remove the cover, you're looking for what happened to the eye under cover when you broke fusion. So we talked about latent strabismus or phorias are controlled by the fusional mechanism. When you cover one eye, you break the fusion because now only one eye is sending the image. So you've broken fusion. Because of breaking fusion, the latent strabismus will become manifest. When you uncover the eye, you'll be able to see the deviation, and the patient subsequently may show an eye movement because it's moving to take up fixation again and get binocularity back. And that movement can be picked up and you can diagnose the phoria that the child or patient may have. You need to measure this deviation for distance and near, preferably give a fixing or an accommodative target for near and for distance so that you can control the accommodation and you know what is the deviation for exactly that distance. As I say, as I've written, always use an accommodative target. For smaller children, use brightly colored objects or toys which the child has to actually see its components with. Measure deviation for with and without glasses. It's very important. We just saw how it can make a difference to the amount and the presence of deviation. Measure it for both distance and near because it's important to know what happens. And of course, in accommodative isotropias, the isotropia may actually increase for near, and that again is a diagnostic test. You need to look for A and V patterns. You need to look for up gaze and down gaze. You look for primary gaze, up gaze and down gaze. You can get an idea whether there is an A pattern or B pattern. You can either move the head or you can move the target up or down. Again, for prism bar cover test is a way to actually measure the actual amount of deviation that the patient may have. Again, we talked about giving a fixing target for both distance and near. You need to do an alternate cover so that you dissociate. And while you're doing that, you need to change the amount of prism, or you can use a prism bar and gradually move it up and down. And therefore, the end point is when there is no movement on alternate cover, you may actually go beyond to see that there is an overcorrection and then come back and do the optimization of the actual amount of deviation that is there. You cannot add prisms over one eye. So if you have, say, loose prisms, you cannot, or you have reached the upper limit of 40 and the deviation is much more. You can't add a 40 and a 20 over one eye. You have to distribute over two eyes because the sum of these two prisms is not equal to the numerical sum of their total. So you may divide these prisms over both the eyes and then come to the final total. I hope it's understood how we are going to do a prism bar cover test. Of course, it's a demonstration or a practical test, and it may be a little difficult to understand theoretically. In patients in whom one of the eyes is not having good vision or has poor vision, or in sensory tropias, you cannot do the prism bar cover test because there is no neutralization. One of the eyes may not be able to move to take up fixation because of poor vision. In those conditions, we do a Krimsky or a prism reflex test. We place the prism on the fixing eye, we force it to deviate, and all in the while we see the deviation reducing in the deviating eye. And once we have what is the final position where we want the eye to be, we measure, that is the amount of deviation we need to correct. That is the deviation in the deviating eye, although we have used the fixing eye to measure the amount of deviation. Earlier, of course, Krimsky described it on the deviating eye, but of course it is easier to see the reflex on the deviating eye straight away rather than through the prism. So a Krimsky test is useful to measure the amount of deviation in eyes that are not seeing or in sensory tropias. The next most important thing to do is ocular movements. You need to do both ductions and versions. What are versions? Binocular eye movements, but there's something more to it. Ductions are uniocular eye movements, versions are binocular movements. What else is there to versions?
There's a question, sir. Why don't we use torch as an accommodative target?
So torch is not an accommodative target because there is nothing to accommodate to on a torch. An accommodative target means that I have to actually identify or see for subtle components of that. Torch is a general illumination which I can look beyond, and there is no actual object for me to focus on. You need to get the eye to see. So it's like a toy or an alphabet where the patient has to actually cognitively see and therefore accommodate and control the refractive status of the eye. In a torch, there's nothing to actually see. So there is no blur which causes a controlled accommodation of the for the brain to control. So that is why torches are not accommodative targets. Alphabets, numbers for small children, toys with features, there has to be a feature on the object. Eyes on a dog. So that's what the child will actually accommodate and focus on. That's why they are not called accommodative. They are not accommodative targets. Child may just look beyond the torch or maybe accommodating or looking at a little further away or a closer object, and you can't just know the difference at all. That's why. So yeah, we were talking about versions. There's something called version. There's something called vergences. How are these two different? Yes.
Yes, anyone?
Ayushi was saying something. So versions are binocular eye movements. We can see that much. Ductions are uniocular eye movements. You need to do both. You can't do without one. You can't do one. So you need to do both. But how are they versions different from vergences? We were talking about vergences just a little while back. So how are they different?
The versions are in same direction.
Great.
Yes, sir.
Versions are binocular eye movement direction. So it's a dextroversion, levoversion. Vergences are binocular eye movements in the opposite direction. So you're looking at convergence or divergence. So just to show you that ductions and versions both are important. So binocular as well as uniocular eye movements. Just to show you this child. So this child appears to be a case of bilateral sixth nerve palsy because either eyes are not deviating outwards when he is asked to look into that. But this child is a child of cross fixation. The moment you close one of the eyes, you can see that induction, the eye is moving comfortably. And he was just using cross fixation in this image. He was looking at the torch of the right hand with his left eye and the left side with his right eye. And that's why the ipsilateral eye to the torch was not apparently moving. So again, duction versions followed by ductions are important. We talked about up gaze, down gaze evaluation. So that's how do not miss oblique overaction. You can see here, there is, whenever you're confronted with 9 gazes, start with the central image. That's the primary gaze for you. Primary gaze, up gaze, you can see that the deviation has increased. Down gaze, you can see the horizontal deviation has reduced. So this is a V pattern. I hope it's clear. Primary gaze, up gaze, down gaze. Deviation, exotropia is less in down gaze, more in up gaze. So a V pattern, exotropia. And then you see in dextroversion, this eye is going up. In levoversion, the opposite eye is going up. And dextro elevation and levo elevation, the eyes are going further up, showing inferior oblique overaction. So bilateral inferior oblique overaction. So it's a exotropia, whether it's a right divergent squint or an alternate divergent squint with bilateral inferior oblique overactions responsible for the V pattern that you can see. Again, here you can see an isotropia. So again, you start with the central image. This eye is fixing, this eye is deviating inwards, the reflex is outward. So this is an inward deviation of the right eye, right convergent squint. Up gaze, the convergence squint has increased. Down gaze, the convergence squint has decreased. This is like an A pattern. Similarly, when you look in dextroversion, this is a little lower than this eye. This in levoversion, this eye is a little lower than this eye. So as you go into levo depression, you can see this eye is further lower than this eye. Dextro depression, this eye is lower than this eye. So this is a case of a right convergent squint with bilateral superior oblique overaction manifesting with an A pattern. Any doubts you can ask, otherwise this is how you interpret a 9 gaze. Start with the central image.
There's a question, how to divide prisms and what will be the position of base on the other eye?
So always the base is going to be the same. For isotropias, you're going to do a base out. So base out in the right eye, base out in the left eye. firstly that. And the first question was, how do you divide? So, but there's not, I mean, it's not something that there is any mathematical rule to division. I have, say, a prism bar, which is maximum 40. So I'm confronted with, say, a 60 prisms of Isotropia. So I'll put, say, 40 prisms fixed over the right eye. And then I start moving the prism bar over the left eye from, say, 10, and I keep going up, 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 up. And when I find that it has actually neutralized on 20, I know that 40 plus 20, the deviation is 60 prisms. So that's how. So there's nothing, no brainer into dividing the prisms. As I said, the important thing is to separate them and divide them over both the eyes. So you can't stack that 20 over the 40 over the right eye, because as I said, the 40 plus 20 is not equal to 60 prisms. I hope that's clear. I hope seeing and understanding 9 gazes is clear, and seeing and understanding pattern strabismus and identifying oblique overactions is clear. Of course, again, you need to see a live patient to actually see the oblique overactions, but particularly inferior obliques are more common. You can see this hypertropia here, which is increasing in evo elevation, and similarly left eye hypertropia, which increases in dextro elevation. So inferior oblique, superior oblique. Important to know, because management of A and V patterns, if there is oblique overaction, you're going to weaken the obliques along with the horizontal surgery. If there is a pattern, significant pattern, however, no oblique overactions, you will do shifting of the horizontal muscles vertically, and for the medial rectus towards the apex of the pattern, and the lateral rectus away from the pattern. So this is why it's important to see the patterns and how you are going to manage the patterns. We're done with competent. I just have a few slides on incompetent and then a little bit about binocularity. So any questions till now we take, otherwise we move on to a little more challenging topic of incompetence strabismus. So no questions means we are good to go. So we'll talk about incompetence strabismus. I talked about incompetence strabismus being that there is a difference in the amount of strabismus and different angles of gaze. Patients will present with, of course, most commonly diplopia, abnormal eye movements, as in one eye is not moving adequately, a limitation, restriction, inability of the eye to move in a particular direction. And sometimes, of course, the patient may come with anomalous head posture, where he's trying to fuse the images because he can have binocularity in that gaze and can avoid uncomfortable diplopia, and therefore he may have a head posture. So you need to look at the head posture. We talked about the head posture. Incompetence strabismus, the most common indication or reason for head postures. Measure the deviation in all 9 gazes. We saw the 9 gazes in competence strabismus, but you need to see them in incompetence strabismus. It's all the very more important, because the deviation is going to change, and to understand which of the muscles are involved, you need to see them in all 9 gazes. A diplopia charting will help us to understand what's happening to the patient. A Hess chart or a Lee's chart or a Lee's screen is charting out the movement of one eye using the other eye, and it is a very, very helpful technique. But again, it's a very practical demonstration. So maybe unless you have a question on that, we'll probably skip that. I'll show you how to do a forced duction test, a forced generation test, and a forced duction test is to assess the presence of a restriction. So you have an eye that is not, say, abducting. You want to know whether it's because of paralysis of the lateral rectus of that eye, or there is a contracture, or there is a limitation which is not allowing the medial rectus to relax and allow the eye to move out. And that will be told to us by a forced duction test. A forced generation test is when the FDT is positive, and I still want to know whether there is some function in the what was earlier a peritic muscle. So I'm going to look for a twitch or a tug, and that's called the forced generation test. We'll just be seeing that. This is a Parkes 3-step test to identify a superior oblique palsy. And can we have an idea of which eye is affected in this Parkes 3-step test? Anybody? And how are we interpreting this Parkes 3-step test?
Left palsy.
Great. And how are we coming to this conclusion?
Sir, left hypertropia, head tilt towards the right, and face turn towards the same side.
So we are not interpreting as head posture, and head tilt test was the Bilchowski's head tilt test, which was a single test, which of course is a little less sensitive than the Parkes 3-step test. So we'll just run through the Parkes 3-step test. which is a relatively diagnostic test for superior oblique palsy. So you have this eye here, primary gaze. As I said, we always start with primary gaze. This eye is a little hypotropic. You can see centered here. This eye is, theoretically, you'll say a little hypotropic. So there is an L by R. This eye is fixing. In this case, dextroversion, this vertical deviation has increased, or the L by R is more. In this case, there is very little L by R. It is reduced from what it was in primary gaze. Then we do the head tilt test in dextroversion. In right-sided tilt, there is very little deviation. But as you were mentioning, the ipsilateral head tilt, you can see the vertical deviation is markedly increased. So there is an increase in the vertical deviation on ipsilateral head tilt test. So because you gave some wonderful answer, let's go on to ask you, why does the hypertropia increase on ipsilateral head tilt test? So this is the gold Viva question. Viva gold question. You're going to get distinction marks if you answer this question.
Sir, give an incentive. Nobody will answer on a distinction mark incentive.
Arey, kya baat kar rahe ho, bacha? So Vishal, you will have to do the honors. Huh? It is a tough question. It does require understanding of the ocular motility and the system. So anybody just try a guess? What happens? Why is the ipsilateral head tilt increasing the amount of vertical deviation? And of course, it decreases on the opposite side. And that is why the most common head posture for superior oblique palsy would.
So as we tilt the head towards the left side, there will be intorsion of the eyes on both the sides. So something related to intorsion and extorsion, but I'm not very clear, sir.
Right. So great. So when you tilt so in this photograph, as you can see, when you tilt onto the left side, what is normally happening? The eyes are moving to try and keep the image straight. So the eyes will, torsional movement will happen. So the left eye will encyclotort, the right eye will excyclotort, so that the image remains straight on the fovea. Now, what is happening? What are the encyclotorters that we have? Which muscles are responsible for encyclotorsion?
Superior oblique and superior rectus.
Great, superior oblique and superior rectus. So now we have both of them. In normally, the moment I tilt my head onto the left side, the left superior oblique and superior rectus will contract and try and keep the image straight. So when that happens, the superior rectus is an elevator, the superior oblique is a depressor. Both of these two neutralize each other. The superior rectus is an adductor, adductor. Superior oblique is an abductor. I hope we understand why that's happening. So superior oblique is an abductor. These two movements of the superior oblique, superior rectus cancel each other out. But both are encyclotorters, and therefore pure encyclotorsion occurs when I tilt the head onto the left side in my left eye. Now we are dealing with a superior oblique palsy. So what is happening? The impulse goes to both the superior rectus and the superior oblique to do an encyclotorsion. Unfortunately, superior oblique is not able to obey the command. So the superior rectus acts, and it is not opposed. So its vertical pulling action is not opposed by the depressor action of the superior oblique, and therefore the eye goes into hypertropia. There is, of course, less than optimal amount of encyclotorsion, but that is not what we are seeing. We are seeing the eye going up because of the unopposed vertical action of the superior oblique that is not opposed by the depressor of the superior oblique. So that's why the ipsilateral head tilt is so good. And why does the patient prefer to have a head tilt onto the opposite side? How does that help? Why would he prefer to have an opposite head tilt, which is a common head posture for superior oblique palsy? So why a right head tilt for a patient with left superior oblique palsy? Maybe I'll ask this question in a different way so you'll be able to answer this question. Obliques is always a challenge. What will be the head posture for a patient who has a left sixth nerve palsy or a left lateral rectus palsy?
The direction of action of muscle.
Right. So it is actually to do with the direction of action. So if you have a left sixth nerve palsy, the head posture is going to be a left face turn, because that way he is able to eliminate the requirement of the action of the paretic muscle. The right, in a left sixth nerve palsy or a left lateral rectus palsy, the leftward movement is affected. So he prefers to keep both the eyes in the right gaze, and therefore will have a left head posture. So similarly for the superior oblique, so corollary is in the superior oblique palsy. When he tilts to the right side, the left eye is now excyclotorting. Right? Clear? We were talking about encyclotorsion of the left eye on left-sided head tilt. On the right-sided head tilt, the right eye is encyclotorting, the left eye is actually excyclotorting. So the muscles that bring about excyclotortion are inferior rectus, inferior oblique. When impulse goes to the inferior oblique, by the Sherrington's law, actually the antagonist, which will be the superior oblique in this case, will get inhibited. Because there is no action of the superior oblique, its weakness is not manifested. Just like in a left lateral rectus palsy, when the patient looks onto the right side, the weakness of the lateral rectus is no more there. So his eyes may be aligned and he may not have diplopia. So on right-sided head tilt, the superior oblique is not doing any action. So the weakness is covered. It's like when you're playing, I mean, when you have a poor fielder in a cricket match, you're going to put him way back at the boundary. He doesn't have to do the catching. He doesn't have to run to stop the ball. So similarly, his head posture will be such that it is minimally required to put action to the paretic or the paralyzed muscle. So that's why they prefer to have an opposite side head tilt. I hope that's good. So diplopia charting, dark room, use a slit light source. So we would prefer to stick a chart or something with a slit in the front and then do the diplopia charting so that the patient is able to easily identify the two straight lines as separate. So the diplopia becomes clear. You need to have red-green goggles and have a slit light source, horizontal for vertical deviations and vertical slit for horizontal strabismus, and also ask for torsion or tilt of one of the lines, because that will tell us that there is a torsional strabismus also. Whenever patient complains of diplopia, you need to know whether it's uniocular or binocular diplopia. You need to see where the patient has maximum diplopia and where there is single binocular vision. Measure the distances between the two images, essentially to know how the distances are increasing and whether the images are inclined or straight. And of course, is the diplopia crossed, a heteronymous diplopia or an uncrossed diplopia? Again, that would be obvious by the deviation itself. So this is a case of a left sixth nerve palsy. You can see there is a left abduction deficit. Here the eyes are aligned. So in dextroversion, there is a single binocular vision. There is a small deviation which increases on levoversion. So left sixth nerve palsy, this is how the patient will be appreciating the diplopia. Restriction versus paresis, a force reduction test, an active force generation test, and saccadic velocities. Sometimes difficult to measure or see significant difference in a small paresis. But if it is paralyzed, you will see very clear differences. I'll just show you forced reduction test. Patient, there was a lateral rectus palsy. I was not abducting. We put anesthesia, hold it at the opposite limbus and rotate the eye. In this case, this FDT is negative. There is no restriction on the medial side, and therefore the limitation of abduction is because of paresis or paralysis of the left lateral rectus. Now, suppose the FDT was positive. It was a tight FDT and I'm not able to move the eye at all because I feel a tightness. Now, I do not know that this tightness is only that is responsible for the limitation of movement. And if I just release this, will I get normal movement or not? And whether the lateral rectus is also paralyzed or not. For that, I look for active force generation test, AFGT. So I'll just show you and then we'll. So the patient is now held here and then asked to look in that gaze. You'll feel for a tug. The eye, is not moving, but you're feeling for a tug to see whether there is some pull by the lateral rectus that is opposed by the tight medial rectus. So this is an active force generation test to assess the power in a paralyzed muscle. So those are key tests for paretic strabismus to identify the type of strabismus and of course the muscles that are causing it. and how, of course, get an idea of whether it's peritic or restrictive, and which will decide how you're going to manage them. And finally, the key things that we see is in torsion. You have subjective methods to measure torsion and objective methods. Subjective is a double Maddox rod. You can put 2 Maddox rod and the patient will see 2 lines perpendicular to the striations, and you can ask him to rotate one of the Maddox rod to make them parallel with each other, and the amount of rotation he has to do will tell you how much torsion he has. So this is the way to measure torsion subjectively. You can do it on a synoptophore or even a scotometer. Objective methods are indirect ophthalmoscopy and a fundus photography. So you need to actually see, normally the fovea is going to lie in the lower third of the disc. And if it is deviated up or down, you're going to be able to appreciate. So you can see that this is just below here. So not significant, not so much torsion in the right eye, but in the left eye, you can see if you draw a parallel line, a line here, tangential to the lower edge of the disc, you can see that the fovea is shifted below, and therefore there is a torsion in this patient. This is an important objective method doing fundus photography to measure and to actually see for torsion, and it can be done pre and post surgery to see the amount of change in the torsion. A binocular status, when you are to assess, the simplest is the Baglioni stride glasses, Worth 4-dot test, which is available in every Snellen's, and of course the synoptophore and more tougher tests like the after image test. But Baglioni stride glasses, these are striations at 45 degrees and 135 degrees. You show a point source of light, which is converted to a streak because of these striations. This is a cross response, meaning that the patient has binocularity. There is a foveal suppression. So one eye has a full line, the other eye has a central scotoma. So there is a foveal suppression, and this is a complete suppression. So in this eye, you can see that these striations are, the line is complete, but here there is no line. So one eye is suppressing. So this is the simplest and the most physiological way to assess whether there is binocularity or not. You can do using the Worth 4-dot test. Very simple. Again, all you need is red-green goggles, and the Worth 4 dots are available in all Snellen's charts, below all Snellen's charts. So again, you can appreciate and understand what is the level of binocularity, or what is the binocularity that the patient has. A more deeper or a more complex binocular status is the presence or absence of stereopsis or depth perception. You have multiple ways. I'm just showing you, this is the TNO, in which we use red and green goggles for dissociation. This is the Randot test, in which we use Polaroid glasses. They give you a very accurate the amount of stereopsis that a patient has. And I would recommend all residents should undergo stereopsis. If they have poor stereopsis, it will tell them why they are having increased amount of PC ranks. So, and of course, these are ways to measure stereopsis for both distance and near. You have distance stereopsis in the form of the Frisbee-Davis, which is a real depth test. So these are images which are on a slide, on a rod, which can be slid front and back, and you can move these objects and really create the depth. And therefore, this is called a real depth perception test, whereas all these dissociate the eyes using one form or the other. So like red-green goggle dissociation or a Polaroid dissociation, by which you artificially create or pseudo stereopsis tests by which we are able to measure the depth or the stereopsis a patient has. So this is, as I said, a Frisbee-Davis distance or an FD2 stereo test. The Randot is also available in a distance Randot. The principle remains the same. And I think we move on to this question. Any other questions before we go on to what Vishal had asked to, have a set couple of questions for entertainment?
So are we moving to the quiz now?
I guess so, unless they have any questions. Unless they quiz me before I quiz them.
There was one question, sir, like, how do we measure the centration of glasses?
That is, I would say, one of the most difficult things to do in life. They can do abrometry, they can do refractive procedures, they can even discuss delamination and vitreoretinal surgery, but when it comes to centration of glasses, it becomes the most complex question for a junior resident. It's unfortunately, I mean, it's a demonstrated thing. You actually need to hold the spectacles in your hands and see. Of course, a POG or a focimeter where you are testing for the power of glasses, the first step is center them, because you need to place them in the exact center so that you're able to get the accurate amount of power of that lens. So of course, the simplest way is to use a focimeter or when you are checking the POG, it will mark the center. But otherwise, clinically, you need to hold the glasses or the lens against a line or any straight line, and you need to be able to see that straight line from outside and inside the lens. As we discussed, that decentration causes a prismatic effect. So depending upon whether it's a convex or a concave lens, base in or base out, the line will not be straight if you are looking at from the edge of the lens. The line will be deviated towards the base of that prismatic effect of that lens. And when you move the lens and you are able to see a single straight line, the line is continuous both outside and inside the lens, you will be able to, so that line is passing through the center. So you need to do this in two axi, horizontal and vertical, or essentially approximately 90 degrees to each other. And where those two lines cross, that is the actual center of the lens. So you need to mark that on the lens, make the patient wear his spectacle, and then see whether that mark, that point that you have made, is actually bang opposite the pupil or the center of the pupil when the patient is looking in the distance. So that's how centration of glasses can be checked. As I said, it is the most difficult test to do. I hope it is understandable. I mean, like I said, without actively showing you, it may be a little difficult, but that's how you need to actually pick spectacles, pick up a glasses and just try it, and you'll understand exactly what I'm saying. It's a very simple, just straightforward. Just see for a continuous line, both outside and inside the lens in two axi, and that's the point.
That is pretty important also, because when you give very high powered glasses, whether they are myope or hypermetropes, and you're looking for, controlling strabismus, you need to have a good centration of glasses. Otherwise, the vision also falls and the alignment also is haywire. So as sir rightly mentioned, that a lot of focimeters have, easy mark on it. So just put it on the focimeter and it puts a dot on it, and then you can just put it on the patient's face and check it. Otherwise, it is little to be demonstrated, as he said very rightly. Any other question?
Although I'll say that is not the answer. Focimeter is not the answer.
That's not the answer. That's not the
examiner is looking from you.
Yeah.
We can proceed to the quiz.
Right.
Sir will be presenting two questions for two grand prizes, and you will get 10 seconds. So 10 seconds is enough for your level of...
Yeah, they are MCQ, so they just have to say 1, 2, 3, 4, depending upon...
Don't speak up on the mic, just type your answer, and whoever types the first will get the grand prize delivered to his or her workplace. So you can proceed.
Okay, so we go on to the question. The diagnosis is infantile isotropia, isodvance, superior oblique palsy, lateral rectus palsy. 1, 2, 3, 4.
The time starts now. Okay, sir, time up.
Time up. We'll talk the... So anybody wants to give the answer?
Now you can put your mic on and tell the answer.
The 2.
Isodvance. Great. Yeah, absolutely right. Hopefully.
Very good.
So Ayushi Gupta, I think...
There is an explanation also required?
No explanation required. It's straightforward. If they have diagnosed, they've diagnosed. I'll just, of course, tell you why it's an isodvance. You can see a small amount of isotropia, and you can see a significant amount of abduction deficit. So this is a characteristic of a restrictive versus a paralytic strabismus. Also, you can see that retraction and the widening that you can see. So on attempted abduction, there is widening. On attempted adduction, there is narrowing. So a discrepancy in the amount of isotropia versus the severity of limitation of abduction is one of the very characteristics of a restrictive versus a paralytic strabismus. And of course, the retraction that you can see in Dwan's. So I guess, great, we move on.
Yes, sir. Next question.
So we go on to the next question. This is, you need to tell me what test is being done. Identify the test, cover uncover test, alternate cover test, prism bar cover test.
Time starts now.
So,
Time up.
yes.
We have got all sorts of answers, sir.
Yeah. And it's all 1, 2, 3, 4.
All 1, 2, 3, 4.
Oh, sorry, I forgot.
No, 3 is not there.
But yeah. Very good. So, in just one procedure, we can do all the 4 tests. So this is a cover uncover test. The eyes were aligned. I put a cover over one of the eyes. When I removed the cover, so I'm looking at this eye has not shown any movement because they were anyway aligned. You can see the eye was deviating. There was a phoria. When I removed the cover, the eye came back to take up fixation. So this was a cover uncover test or an uncover test. And this was to pick up phorias.
Most have answered cover test. Only few have answered cover and
Cover and cover test. Yeah.
Great.
Isha Chaturvedi is the winner
Isha
here.
Chaturvedi is the first one, I
So
guess.
I can stop share.
Yes, sir, you can stop.
I just wanted to say thank you for your attention.
Vishal. Hi,
Rohit,
Rohit,
sir,
sir,
how are you? Good evening, sir.
How are you, sir?
I am fine. मैं तो तुम्हारी टॉक सुनने के लिए बैठा हूँ अभी यहाँ.
क्या बात है सर, क्या बात है. Thank you very much.
तो नहीं, wonderful talk. You have in very short, you explained everything. This is basically a IC. आप इनको बच्चों को अपने किताब के बारे में भी तो बता दो if they are interested.
सही बात है सर.
Sir,
So with sir, we have written a book on pediatric ophthalmology and strabismus. Sir has been, of course, the major drive behind the book, and we've got authors from all over the world. And I mean, frankly, even though I say it, it is an excellent book for pediatric ophthalmology and strabismus. Unfortunately, we have not, advertised or informed adequate number of people, and we are in the process of doing that. But it is a good resource book for anybody who's interested in pediatric ophthalmology and strabismus.
And it is available on JP Brothers. So it's all available online also, and available on JP Brothers. Anybody can write to them. JP Brothers publishers.com ka hai, and they can purchase from there. A lot of people have already purchased what the publisher told me.
thank you, sir.
So,
So thank you all residents, ROS executive and respected teachers, and especially Rohit sir for the excellent teaching on strabismus today. And we look forward to the next class in the coming weeks with more residents on the hot seat. Thank you, and keep giving your feedback and suggestions for the Kaksha experience to improve. Do also subscribe to the ROS official channel on YouTube, where all previous lectures have been uploaded already. And good night from Team ROS. Thank you, sir. Thank you so much.
Thank you very much.
Thank you, everyone.
The mouth must be dry. You need water.
Thank you. Yeah.
Thank you, sir.